time. Now we are going to continue with the question number 13. So, an 83 years old woman comes to the office due to 1 year history of progressive, severe, crampy abdominal pain that occurs immediately after she eats. Okay, that occurs immediately after she eats. The pain is diffuse but more pronounced in the epigastric area and is associated with a frequent bloating and nausea and occasional diarrhea. The patient has had a 15 kg weight loss over past year. She has lost her appetite and the pain since the pain episodes began. Her other medical problems include hypertension, type 2 diabetes mellitus, hypercholesterolemia, peripheral vascular disease and coronary artery disease. 3 years ago, she suffered an inferior wall myocardial infarction which was treated with a drug-eluting stent. The patient has a 40-pack year history of smoking but quit 10 years ago. Since she occasionally drinks a glass of wine, temperature is 36.8 degrees Celsius, that is 98.2 degree Fahrenheit. Blood pressure is 140 by 92 millimeters of mercury, and pulse is 80 per minute, and respirations are 14 per minute. The BMI is 24 per kg, 24 kg per meter square. Abdomen is soft, non-tender, and non-distended. The bowel sounds are present. Abdominal X-rays reveal no abnormalities. Which of the following is the most likely cause of this patient's current presentation? And out of these options, the answer of choice is option A, that is atherosclerosis of the mesenteric arteries. The educational objective of the question is the diagnosis of chronic mesenteric ischemia should be suspected in the patient with unexplained chronic abdominal pain, weight loss and food aversion. Most cases are due to atherosclerotic changes of the celiac or superior mesenteric arteries. Now here you can see that chronic mesenteric ischemia etiology, it is atherosclerosis, smoking and dyslipidemia. The clinical features include crampy postprandial epigastric pain, food aversion and weight loss. Diagnosis is signs of malnutrition, abdominal bruit, CT angiography that is preferred, Doppler ultrasonography can also be done. The management is risk reduction, for example tobacco reduction and nutritional support. Endovascular or open surgical revascularization can also be done. This patient with a history of vascular disease most likely has a chronic mesenteric ischemia. Chronic mesenteric ischemia mostly present with crampy postprandial epigastric pain, that is intestinal angina, food aversion and weight loss. Patients may also report nausea, early satiety and diarrhea. The anginal pain frequently starts within first hour of eating and slowly resolves within the next 2 hours. The pathophysiology of the pain is most likely related to shunting of the blood away from the small intestine to meet the increased demand of the stomach. In patients with atherosclerosis, the celiac or superior mesenteric arteries may be narrowed and unable to dilate appropriately to maintain the adequate blood flow to the intestines. Physical examination may show signs of malnutrition and may reveal an abdominal bruit in about 50% of the patients, but can be otherwise unremarkable. Although abdominal X-ray and CT scan may demonstrate calcified vessels, diagnosis requires better visualization of the vessels. CT angiography is preferred choice, although Doppler ultrasonography may also be helpful. Treatment involves risk reduction, for example tobacco cessation, nutritional support and revascularization. Option B, that is intermittent increase of the intra-gallbladder pressure, that is not the option of choice, because the biliary colic occurs as gallbladder contracts against an obstructing stones, transiently raising the gallbladder pressure. The pain is often localized to upper right quadrant and does not occur after every meal. Significant weight loss is very rare. Option C, that is left ventricular aneurysm, it was not the option of choice because the ventricular aneurysm, which is scarred myocardium following the transmural myocardial infarction, predisposes to acute mesenteric ischemia rather than chronic mesenteric ischemia due to thrombus formation and embolization. The presentation of acute mesenteric ischemia is abrupt with severe abdominal pain out of proportion to the examination findings. Both in pathophysiology and acuity, acute mesenteric ischemia is analogous to acute myocardial infarction, where the chronic mesenteric ischemia is similar to the stable cardiac angina. Choices D and F. So progressive pancreatic inflammation and transmural inflammation of the small intestine, none of them was the option of choice because the pain accompanied by the malabsorption may be due to chronic pancreatic or Crohn disease, chronic pancreatitis or Crohn disease, that is transmural intestinal inflammation. However, these diseases frequently produce abdominal CT scan and X-ray findings of, for example, pancreatic calcifications. In addition, this patient does not have a risk factor for pancreatitis, for example, heavy alcohol use. Crohn disease generally present at an earlier age and usually cause lower right quadrant pain. Choice E, that is over here, selective hypersensitization of visceral afferent nerve. It was not the option of choice. Irritable bowel syndrome does not usually lead to significant anorexia and weight loss. If presents, these features should prompt the consideration of other diagnosis. The next option, the next question, question number 14. A 2-day-old boy is evaluated in the newborn nursery for a diffuse rash that has developed this morning and appears on the patient's face, chest, abdomen, and extremities. He has been breastfeeding every 2 to 3 hours and voiding frequently. The infant was born 40-week gestation to a 30 years old woman by vaginal delivery. His mother occasionally developed cold sores during stressful events. Most recently, a year ago, the mother also has a chicken pox as a child. Temperature is 36.7 degrees Celsius and pulse is 132 per minute and respirations are 42 per minute. Physical examination shows scattered, blanching erythematous papules and pustules that spare the palms and soles. The rash is shown in the exhibit A and exhibit B. I'm sorry, in this question bank I have none of those exhibits, but let's go with the history. Which of the following is most appropriate next step in the management of this patient? So among these available options, the best answer choice is option C, that is parental reassurance. The educational objective of this question is erythema toxicum neonatorum is a benign neonatal rash characterized by the blanching erythematous papules and pustules. Erythema toxicum neonatorum is a benign neonatal rash characterized by the blanching erythematous papules and pustules. It resolves spontaneously within 2 weeks of birth. So here you can see that there is a table: neonatal rashes, diagnosis, the clinical presentation and treatment. So erythema toxicum neonatorum, it is asymptomatic. Scattered erythematous papules and pustules will be present, and the treatment is not required in erythema toxicum neonatorum. Neonatal HSV, there are 3 types. First one is vesicular clusters on skin, eyes and mucous membrane. On the skin, on the eyes and on the mucous membranes. CNS infection and fulminant disseminated multi-organ disease can also be seen. And the treatment of choice for the neonatal HSV is acyclovir. Then staphylococcal scalded skin syndrome, there is fever, irritability. Diffuse erythema will lead to flaccid flexural blistering and positive Nikolsky sign. Oxacillin, nafcillin and vancomycin are the treatment of choice for the staphylococcal scalded skin syndrome. Then asymptomatic erythematous papules and pustules in a healthy neonate are suggestive of erythema toxicum neonatorum. Then we have toxicum is a misnomer as the rash is benign and evanescent. The etiology is unknown, and erythema toxicum neonatorum pustules have been shown to be sterile and to contain many eosinophils. They are sterile and they contain many eosinophils. Erythema toxicum neonatorum is common in full-term neonates in the first 2 weeks of the life. The rash typically evolves from papules to pustules and may wax and wane and can occur on any part of the body, although it spares the palms and soles. Erythema toxicum neonatorum is a clinical diagnosis, and diagnostic workup and treatment are unnecessary. Parents should be reassured that the rash resolves spontaneously without sequelae. The option A, that is bacterial blood culture and intravenous antibiotics, it was not the option of choice because the neonates with the staphylococcal scalded skin syndrome are ill appearing and febrile. Diffuse erythema progresses to flaccid blisters on flexor surfaces and blood culture and promote the anti-staphylococcal therapy. Anti-staphylococcal therapy are indicated due to the risk of septic shock. In contrast, the neonates with the erythema toxicum neonatorum are well appearing and afebrile. The option B, that is contact isolation and cessation of the breastfeeding, it is not the option of choice because the contraindications to the direct breastfeeding include the herpetic breast lesions and peripartum varicella infection. This mother has a history only of herpes labialis and childhood varicella infection and should be encouraged to breastfeed. The choice E, that is topical corticosteroids, it is not the option of choice. Yes, topical corticosteroid is not the option of choice because the topical corticosteroids are indicated for inflammatory diseases like eczema or not erythema toxicum neonatorum. The choice F, that was viral DNA testing and intravenous antiviral therapy, it is not the option of choice because the herpes simplex and varicella zoster virus infection in the neonates can present with the vesicular clusters and lead to fulminant disseminated disease. The viral DNA testing and acyclovir administration are indicated in these cases. The lack of vesicle or exposure to active maternal lesion in this patient makes these infections very unlikely. The next question is question number 15. They are asking about a 60 years old man who comes to the emergency department with a 10-day history of malaise and lower back pain. He has tried high dose acetaminophen with no relief. His past medical history is significant for the benign prostate hyperplasia (BPH) and recent urinary tract infection treated with ciprofloxacin. He reports resolution of the urinary symptoms. His temperature is 38.3 degrees Celsius, that is 101 degree Fahrenheit. The blood pressure is 120 by 76 millimeters of mercury and pulse is 90 per minute. The respirations are 16 per minute. The physical examination shows exquisite tenderness over the L4 to L5 vertebrae and local paravertebral muscle spasm. Neurologic examination shows 2 plus deep tendon reflexes and 5 by 5 muscle strength in all extremities. The straight leg raise test is negative at 60 degrees. The prostate is mildly enlarged and non-tender. The lab results are as follows. Hemoglobin is 12.4 gram per deciliter, that is normal. The platelets are 400,000. The leukocytes are present, like leukocytosis is there. Neutrophils are 63%, bands are 4%, eosinophil is 3%, lymphocytes are high in number 23%, monocytes are 6%, and ESR is 75 millimeters per hour. The plain X-ray of the lumbar spine shows mild degenerative changes. What is the best next step in the management of the patient? And among the available options, the option of choice is option B, that is magnetic resonance imaging of the spine. Educational objective of this question is yes, over here. Vertebral osteomyelitis usually presents with fever, back pain and focal spinal tenderness. Evaluation includes blood culture and inflammatory markers like erythrocyte sedimentation rate and C-reactive protein. The magnetic resonance imaging is the modality of choice for the diagnosis, followed by the computed tomography guided bone biopsy. Now here you can see this flow sheet. Evaluation of the vertebral osteomyelitis, fever, back pain and focal spinal tenderness. You should do the blood cultures, check the ESR and C-reactive protein and the plain spinal X-rays because you are suspecting osteomyelitis. If there is increased erythrocyte sedimentation rate and C-reactive proteins but normal X-rays, then you should do the MRI and CT guided needle aspiration biopsy can also be done. But firstly you have to check for the blood cultures ESR CRP and do the X-rays. If the X-rays come out normal with increased ESR and CRP, go for MRI and then you can go to the CT guided needle aspiration biopsy as well. The patient's presentation of fever, back pain and focal spinal tenderness suggests vertebral osteomyelitis, most likely due to the hematogenous spread of the recent urinary tract infection. Staphylococcus aureus account for about 50% of the cases of pyogenic spinal osteomyelitis. However, other pathogens including the gram-negative bacilli in this patient can also cause osteomyelitis. Patients often present with a back pain that may be misdiagnosed as degenerative spine disease. Fever may or may not be present. Physical examination shows exquisite focal tenderness on the percussion at the posterior spinous process of the affected vertebrae, increased muscle spasm in the contiguous area and decreased range of motion in the back. Epidural abscess may lead if the infection extends posteriorly into the epidural space and often causes severe back pain with motor and sensory abnormalities which can progress to paralysis. Initial workup includes complete blood count, blood culture positive in 50% to 70% of the patients, erythrocyte sedimentation rate, C-reactive protein and plain X-rays. The leukocyte count may be normal but the ESR and CRP are usually markedly elevated. The plain X-ray can be normal in the first 2 to 3 weeks of infection. Magnetic resonance imaging is the modality of choice for the patient with suspected vertebral osteomyelitis. It can also detect the epidural abscess and cord compression. Radionuclide bone scanning using the gallium is an alternate for the patients who cannot undergo the MRI. Computed tomography guided CT guided aspiration and culture of the infected intervertebral disc space or bone are needed to confirm the diagnosis. The choice A and E that were computed tomography scan of the abdomen and pelvis and the renal ultrasonogram. Both of them were not the options of choice because the renal imaging with the CT scan preferred on ultrasound is indicated in the patient with the suspected complications from the pyelonephritis. These include renal abscess or calculi causing the obstruction. This patient has no urinary symptoms and the spinal examination findings make osteomyelitis more likely. Choice C, that is naproxen and physical therapy. It was not the option of choice because over here the pain control and physical therapy are recommended for the patient with muscle sprain or simple back pain with no fever, recent infection, focal tenderness or other alarm features like history of cancer, etc. The choice D, that is prostate biopsy. It is not indicated in this patient because the prostate biopsy would be indicated if the digital rectal examination shows prostate nodules, induration, or asymmetry. This patient's examination has had no such features. And the choice F, that is technetium bone scan, it is not indicated in this patient because technetium bone scan is less specific than the gallium imaging in the diagnosis of vertebral osteomyelitis, as it also detects fractures and may result in false positive findings. The study may also be negative in early phases of the infection. The next question 16 is asking about a 45 years old man who comes to the office for evaluation of the intermittent episode of cough and dyspnea for 2 months, and he is a 45 years old man. The episode usually occurs after the exposure to cold air outside during the jogging. The patient gets some relief after expectorating white sputum. The medical history is significant for myasthenia gravis. 4 months ago, the patient was intubated for 5 days due to the myasthenic crisis triggered by a viral upper respiratory infection. He takes pyridostigmine and does not use tobacco, alcohol, or illicit drugs. Temperature is high, blood pressure is normal, and pulse is a bit higher, like at 78 per minute. Respiration is 16 per minute. Pulse oximetry on room air is 98%. Examination shows occasional wheezes on the posterior aspect of both the lungs upon focal exhalation. Heart sounds are normal. Muscle strength is 5 by 5 in all the extremities. Cranial nerve function is normal, and deep tendon reflexes are also normal. The remainder of the examination shows no abnormalities. Which of the following is the most likely cause of the patient's symptoms? And among the given options, the best answer choice is option B, that is leukocyte induced bronchoconstriction. So here you can see the educational objective of this question is intermittent asthma is caused by the leukocyte induced acute and reversible bronchoconstriction. So here you can see in this picture that this is alveolus and this is the airway, and this is the relaxed muscle in this picture. And now here you can see that there we are having the muscle spasm, and in the muscle spasm there will be air trapping with hyperinflation, and there is mucus that is accumulating inside the bronchi. The airway has been narrowed and inflamed, and thickened airway wall is also seen. So the discussion is so the discussion of the question states that this patient who was previously intubated due to myasthenic crisis now has intermittent episode of cough and dyspnea. Several features of his presentation suggest intermittent asthma. Important thermomechanical asthma triggers include exercise, for example jogging, and extremes of temperature and humidity, for example cold, dry air and hot, humid air. The mechanism likely involves local changes in the blood flow and neural input that stimulate the inflammatory cells, for example the mast cell and the eosinophil. Activation of the mediator released by the leukocytes in the bronchial wall. Key inflammatory mediators include histamines and leukotrienes, which exert paracrine effects on the adjacent cells in the airway wall. So the adjacent cell in the airway wall include the smooth muscle cells, depolarized leading to bronchoconstriction, and the goblet cells are activated to promote the mucus hypersecretion. These responses account for the cardinal symptoms of an asthma attack like episodic dyspnea, cough and wheezing due to airway inflammation and obstruction. Bronchial edema and hypersecretion may lead to the expectoration of the non-purulent, for example whitish or clear mucus. Mobilization of these secretions alleviate airway plugging, resulting in the partial symptom relief as seen in this patient. In patients with the intermittent asthma, lung sounds may be normal during the calm tidal breathing in intermittent asthma, although wheezing can sometimes be elicited by the forceful exhalation, reflecting the residual activity, the residual airway inflammation and spasticity. Although asthma typically presents in the childhood, adult onset disease is also prevalent and can be triggered by the upper respiratory infections, for example the patient's recent myasthenic crisis, irritants, for example the air pollution, and the allergens like mold. Option A, that is insufficient pyridostigmine dose, it is not the option of choice because the excessive rather than insufficient dosage of the pyridostigmine, an acetylcholine esterase inhibitor, may cause a cholinergic toxidrome of increased respiratory secretions, that is bronchoria and bronchospasm. However, gastrointestinal symptoms like nausea, abdominal cramping and secretory diarrhea usually predominate. The choice C, that is non-necrotizing granulomas. This was not the option of choice because the acute hypersensitivity pneumonitis causes non-caseating granulomas, lung disease, with subacute episode of dyspnea in relation to organic antigens, for example the birds and molds. Intermittent and quickly reversible dyspnea and cough with exercise are more suggestive of asthma. Choice D, that is paradoxical vocal cord motion. The choice D was not the option of choice because vocal cord dysfunction, that is paradoxical closure during the inspiration, can present with the intermittent dyspnea by noisy breathing, for example inspiratory stridor, triggered by the exercise or psychosocial stress. However, it is more common in young women, not typically exacerbated by cold air and unlikely to cause sputum production. Choice E, that is segmental tracheal stenosis. This was not the option of choice because the tracheal stenosis, that is rigid narrowing, or tracheomalacia, that is rigid narrowing or tracheomalacia, that is weakness and collapsibility, are complication of prolonged endotracheal intubation and can cause dyspnea and noisy breathing. The tracheal stenosis is associated with a prolonged, that is more than 2 weeks of mechanical ventilation, and presents with slowly progressive rather than episodic dyspnea, and is potentially accompanied by stridor rather than wheezing. The next question, number 17, is that a 63 years old woman with a long history of hypertension collapses in her church after experiencing the sudden onset of severe chest pain that radiated to her back. She is rushed to the emergency department. On arrival, she is confused and agitated, and the blood pressure is 90 by 50 millimeters of mercury, and the heart rate is 110 per minute. The jugular veins are distended, the lungs are clear on auscultation. An intra-arterial catheter in the radial artery shows significant variation of the systolic blood pressure related to the respiratory cycle, which is pulsus paradoxus. Chest X-ray reveals widening of the mediastinum. Which of the following is the most likely cause of the patient's syncope? And out of the following options, the most likely answer is option E, that is pericardial fluid accumulation. Educational objective of this question is cardiac tamponade can occur as a catastrophic complication of the acute aortic dissection. It should be suspected in the patient with a hypotonia, tachycardia, distended neck veins, and pulsus paradoxus who have sudden onset of severe tearing in chest pain radiating to the back. The discussion states that the patient's clinical presentation is consistent with an acute aortic dissection complicated by the cardiac tamponade. The sudden onset of severe chest pain radiating to the back and widened mediastinum on the chest X-ray are suggestive of aortic aneurysm. The presence of hypotension, tachycardia, distended jugular veins, and respiratory variation in the systolic blood pressure, that is pulsus paradoxus, they are all consistent with the presence of cardiac tamponade. Sorry. So cardiac tamponade can occur as a complication of aortic dissection with rupture of the aorta and rapid accumulation of the blood in the pericardial space. Rapid accumulation of the blood in the pericardial space. An abrupt accumulation of even small amount of the blood can significantly raise the pressure inside the pericardial cavity. Increased pericardial pressure causes compression of cardiac chambers and limits the diastolic filling of the right-sided chambers. This causes a decrease in the preload and reduces the cardiac output, resulting in the hypotension and syncope. Choice A, that is aortic stenosis, it was not the answer of choice because in aortic stenosis, syncope usually occurs with activity. Chest pain is also typically exertional, not as severe as with the aortic dissection, and does not radiate to the back. Physical examination in patient with the aortic stenosis shows pulses parvus et tardis, that is slowly rising and low amplitude pulses. Pulsus paradoxus or widened mediastinum on the chest X-ray is also not present in the aortic stenosis. Choice B, that is cardiac tachyarrhythmias. So the cardiac tachyarrhythmias, including the atrial and ventricular arrhythmias, for example the atrial flutter, fibrillation, ventricular tachycardia, or fibrillation, can cause syncope. They usually do not present with a sudden onset of severe chest pain, pulsus paradoxus, or widened mediastinum on the chest X-ray. The choice C, that is hypovolemia. Hypovolemia was not the option of choice because hypovolemia or intravascular volume depletion typically occurs in the setting of acute blood loss and protracted vomiting or diarrhea. The patients having dizziness and postural hypotension or may present with initially with hypovolemic shock. In patients with a significant intravascular volume depletion leading to syncope, jugular venous pressure is typically reduced with a flat neck veins. And the choice D, that was papillary muscle dysfunction. It is not the option of choice because the papillary muscle dysfunction is a well described complication of acute myocardial infarction. It causes acute mitral regurgitation and presents as sudden onset of pulmonary edema, hypotension, and progression to cardiogenic shock. The papillary muscle dysfunction is usually not a consequence of the aortic dissection. Choice F, that is vagal hyperactivity. The vagal hyperactivity is not the option of choice because vagal hyperactivity is the underlying mechanism behind the vasovagal syncope, a common cause of syncope in the patient presenting to the emergency department. This disorder is characterized by the prodromal symptoms including the dizziness, nausea, diaphoresis, pallor and visual disturbances prior to the syncope. So we'll keep this section till here. Until next time, Allah Hafiz, fi amanillah, and take care.